Hello and welcome everyone to this MSSO webinar, Advanced MedDRA Coding. My name is Suzanne Insur Shakir or Shaker, both are correct. I will be your instructor for this webinar. Joining me is my colleague Hannah Eaton, who is an MSSO training coordinator and will be facilitating our session today. So I'd like to start us off with introductions and a few housekeeping items. I am a medical officer with the MedDRA MSSO. Prior to that, I had a little over 20 years experience in the industry with different CRO and pharma teams within various functional groups, including data management, clinical monitoring, medical coding, pharmacovigilance, and medical device safety, as well as medical data science. I'm based in New Jersey on the East Coast of the United States. And since this webinar offers an interactive session in the second half, you'll be using a tool that's called Poll Everywhere to do some hands-on exercises. At this time, I invite you to please access the Poll EV. You can use either the QR code on your screen or you can use the URL in your browser. You don't need to enter a username if prompted. The polls are anonymized, but this will give us a chance to test out the tool, make sure you can get in, and also a few questions to get to know you better. And the QR code will be visible on the right-hand top corner of your screen if you need it. Okay, so a few housekeeping items as the pins are coming in, and I'm so happy to see pins coming in. This webinar is scheduled for 2 hours. We have a good number of material to cover. The primary focus is to go over advanced coding with MedDRA. We're going to offer many examples in the first half and then spend a good part of the second half with hands-on exercises where you will be selecting MedDRA codes for different verbatims. In the MSSO training curriculum, this course follows after MedDRA Coding Basics. So if you haven't had the chance yet to attend one of those Coding Basics webinars, you can register for an upcoming one or watch one of the recorded sessions on our YouTube channel. Today, we won't be touching upon the browser demo. We won't go into data retrieval with MedDRA nor into SMQs, but we do offer webinars dedicated to those topics. So please check out the MSSO schedule on the meddra.org website if you're interested. It's wonderful to see pins from all over the world, a great testament to the widespread international use of MedDRA as a global standard. We currently have over 20 languages. I think we're up to 24 as of the most recent release. So I see many folks have joined. Maybe some have not yet put their pin, but for interest of time, we do want to keep on going and welcome everyone from all over the world. Happy to have you with us. We appreciate you making the time, whether it's early in the day or late in the day for you. Welcome and thank you for joining. In our next question, I just want to get an idea on how familiar are you with MedDRA. So let's know which of these would best describe your experience with MedDRA. A few more housekeeping items. If you have questions as we go through the slides, please feel free to post them in the chat. Hannah will be monitoring the chat and she can bring them to my attention in between the main sections. I'll try to stop before the hands-on exercises, maybe address a few questions at that time, and then open it up for Q&A at the end. Okay, so I see we have folks that are fairly new to MedDRA, but I also see experienced coders with us today, so welcome everyone. The next question is the last question in terms of getting to know you. So let us know what primary role or roles you perform in your organization. You can choose multiple options if you juggle different roles or have worn many hats in the past. And the last housekeeping item is that Hannah has provided temporary credentials in the chat. You can use them to log into MedDRA browser. You can also, of course, use your own organization's credentials to log into the browser if you prefer. Okay, so as usual, the majority of the folks who joined us are from pharmacovigilance or drug device safety, but we also have a diverse representation across the industry. So another reminder that MedDRA is a valuable tool adaptable to various functional teams. All right, so as many of you know, MedDRA is an ICH M1 standard, so it's an ICH guideline It was created by the ICH in the 90s. The MSSO team, the Maintenance and Support Services Organization, is contracted by the ICH to maintain, develop, and distribute MedDRA with oversight by the MedDRA Management Committee. And that is composed of ICH members, MHRA, Health Canada, and WHO as observer. This is our disclaimer and copyright notice. Just as MedDRA is owned by the ICH, the material I'm presenting today is also owned and copyright protected to the ICH, but you're welcome to use it except for the ICH and MedDRA logos, so long as you acknowledge the copyright, and if you make any modifications or translations that you clearly identify them and avoid any inference that they were endorsed by the ICH. The second bullet point is legal disclaimer that the ICH authors will not be liable for any claims from the use of the presentation. And the third bullet point does not apply today because we don't have third-party materials in this presentation. Okay, so today we're going to be going over advanced principles in the ICH endorsed guideline, which is the PTC document. We're going to discuss concept descriptions. We're going to show several examples of coding with these concept descriptions and advanced coding principles. You can use the browser and the poll EV to test your understanding of these principles that we're going to go through. We're going to wrap it up with a few coding pearls and then open it up for Q&A. All right, so to support the use of MedDRA, the ICH provided an ICH endorsed guide. This is intended for MedDRA users to provide advice for industry and regulatory purposes. So it is titled term selection points to consider, so things to think about when you're coding. And coding is really termed as a term selection. We call it term selection because when you're coding in MedDRA, you're selecting a lowest level term, an LLT, in MedDRA that is the closest matched to your verbatim, with the ultimate objective of achieving accuracy and consistency in coding. And it is highly recommended that this ICH endorsed guideline is the one that you use as a starting point when you're creating your own organization specific coding conventions. And in all my years of experience in the industry, I've never worked on a team that did not have their own organization specific coding convention. This ICH endorsed guide was developed by the ICH M1 PTC working group, and that consisted of representatives of ICH regulatory as well as industry members, in addition to WHO, the MSSO, and the JMO for participation. And JMO is the sister organization to the MSSO in charge of Japanese MedDRA. The PTC working group updates the guide in step with every March release of the MedDRA dictionary, which just came out as version 28 in March. And it's provided in a complete version in 6 main languages and in condensed versions in other supported MedDRA languages, and available on our website and the JMO website. This ICH endorsed guideline is really a great resource because it addresses many, many different types of scenarios you come across when you're coding or when you're reviewing coding. Maybe too many to cover in their entirety today, but we will touch base on a few. And on your screens, you can see examples of these scenarios. This is from section 3 of the PTC document. You see, for example, age versus event specificity. Location versus microorganism specific infections. I'm sure many of you come across terms like that. Even more examples on the second page. Medication errors. What do you do if you have a report that tells you there was no adverse event? How about device terms? So I do strongly advise you to review the document, especially when you come across a verbatim that may be challenging. Please refer to this document, see if you can find a section that speaks to the scenario you're dealing with. And just to show you where you can access this document, so this is the MedDRA.org website, and on the top right-hand corner, the easiest way to open up the PTC guidelines is to use the quick link that says PTC, points to consider. When you click on it, it takes you to the web page that has all the documents. It's the same as if you access it by how to use under support documentation. It just defaults the blue ribbon open. So you see on the top here is the MedDRA term selection points to consider. There's another ICH endorsed guide for data retrieval and presentation with MedDRA, and that has its own webinar. And there's a third document down here, which is the companion document. The companion document is really, really helpful if you're dealing with terms like medication errors, product quality issues, and the newly added manufacturing and quality system issues. So I thought it was nice to just show you how to get to that document. So let's start with a few general principles on coding. We usually cover these in our basic coding webinar. So when you're coding in MedDRA, you're selecting only current lowest level terms, LLTs. You're trying to find the one that is the closest match to the natural language term, to the verbatim that you're trying to code or they're trying to review. So for example, let's say you have a verbatim that says abscess on face. It's not enough to simply code the abscess because MedDRA is a repository that has a lot of detailed information in it. There are options for location-specific abscess terms in MedDRA, like you have brain abscess, lung abscess, neck abscess. So of course, if you look for these LLTs in MedDRA, it's always best to use word stems. So in this example on abscess of face, if you look for abscess and face in MedDRA, you won't be able to find it. But if you use a stem word or just a few letters, then you'll be able to find facial abscess. So if you use the FAC as a stem word, you'll be able to find the facial abscess, but not all dictions, of course, are provided in MedDRA. So not every possible way of conveying a term is in MedDRA. So we do advise to use stem words when you're searching in the browser. And as an important reminder, there are non-current LLTs in MedDRA. You'll see them in the browser with a red box around them. Those are not intended to be used for coding, but they are maintained in MedDRA and kept in MedDRA to be available for legacy conversion for historical purposes. So they're not meant to be used for coding. Another principle is code all the reported information. Now, if you receive information from the reporter and you don't code that to MedDRA, you're not able to retrieve it or use it in data analysis. If you do receive information from the reporter that has a good number of details in it, you should try your best to find LLTs in MedDRA that capture as many of the source details in a single LLT term. But in some cases, that's just simply not possible. You won't be able to find one LLT that conveys the entirety of the reported information you're receiving. And in that case, you may need to select more than one LLT to represent the source term that you've received. Now, having said that, we should also remind you that in certain forms, like AE forms, if you do select more than one LLT for the same verbatim, this could lead to redundancy in your computed counts, basically increasing the number of your AEs. So from a practical approach, each specific organization should document in their coding conventions how they approach these scenarios. Some users with us today may be working in databases that allow the selection of more than one LLT per verbatim or per report. Other users we have on the call today may work in databases where it's a one-to-one correlation. So consult internally if you're not sure about your organization's approach and document your decision. So if you currently don't have an organization-specific guidance, one good practice would be to consult the PTC document, have an internal discussion with your respective stakeholders, preferably not just the coding group, but also from folks who are involved in review and analysis, and then document your procedures and approaches. Ensure everyone is trained and following them consistently. So here's an example from the PTC document. Metastatic gingival cancer. So in MedDRA, there's not a single LLT that captures the specificity of the site of gingival cancer, plus the fact that this is a metastatic carcinoma. You can imagine how much it would overpopulate MedDRA if we added options for metastatic spread to every type of carcinoma. And as the IMOs and the international medical officers who take care of adding terms to MedDRA, we do try hard not to overpopulate MedDRA to avoid signal dilution. So in this scenario, coders will have the option to either code both LLTs if their organization approach supports that, or they can pick only one and document their approach and, of course, apply the approach consistently. Okay, another principle is to get into the habit of checking the hierarchy. So hierarchy in MedDRA goes from the lowest level term, LLT, then you have the preferred term, which is the term that is usually the level you use for reporting, for your analysis. And then we start to see grouping terms, which are the HLT, the high level term, the HLGT, the high level group term, and the SOC, the system organ class. When you're coding, it's always a good practice. Take a look at the LLT you're considering and see which PT it links to. And of course, then which HLT, HLGT, and system organ class the hierarchy contains. It could be a uniaxial term, meaning that it's only linked to one system organ class. It could be multiaxial, meaning that it has more than one system organ class that it's linked to. So this is an accuracy check. It helps you select the best LLT that reflects the meaning of the reported term. So if you're trying to code, for example, low energy, you don't find an exact match in MedDRA for low energy, but you decide that you're going to use worn out. You can check if this makes sense by checking the hierarchy. The level above the LLT will be the preferred term, and in this case, it's fatigue. So that will, comfort you that you've satisfied now that you have the right choice because it matches the concept that you're trying to code. Another check for accuracy and consistency are the MedDRA concept descriptions. These are not medical definitions. MedDRA does not include medical definitions, but they're descriptions. They speak to the use of medical concepts within MedDRA. They clarify how a medical concept is interpreted, how it's used and classified from a MedDRA's perspective, which is needed for an international standard such as MedDRA, since medical practice could differ in different regions of the world. So they're easily accessed directly from the browser. This is a screenshot showing you in the older browser way to access the concept descriptions. But because we had a release of our new web-based browser, I want to show you how to access concept descriptions in the new web-based browser. And you're welcome to click along with me as we go back. So let me go back to home. This is our home. This is the meddra.org website. And to access the old browser, there's the quick link on the top here for WBB. That takes you to the old browser. But to the new browser, you go under How to Use and Tools. And when you open up Tools, these are all the MSSO tools available to you. There's your browsers. And in your right corner, you'll see a link for the new web-based browser. So if you click on that, you have your temporary credentials in your chat that you can put in. Let me just go back to default settings. So this will be your view when you log in. This will be the screen. It's a much more cleaner interface than the older browser. It focuses on the search functionality of the browser, but don't worry, all the functionalities of the old browser are still maintained in the new browser. But to show your concept descriptions, here's your settings. So if you click on settings, you go into documentation, and you have your, of course, user guide for the browser, and you have your MedDRA concept description. So if you click on concept descriptions, an icon will open up that looks like maybe a medical page. It has that medical logo on it. And if you click on that, these are your concept descriptions. They're alphabetized, and you can kind of sort through or either scroll through or click on the letter that you're interested in. There's not a lot of them for these concept descriptions. There's under 90, I believe, maybe 80 some concept descriptions. So they're not meant to convey the entirety of what's in MedDRA, but they do cover terms that may or may not be consistently thought of in the different regions of the world. So abuse and misuse are in here. You have overdose and underdose are in here. So for example, if I go to O and I look at overdose, it tells me that for the purposes of MedDRA term selection, overdose is when you have more than the maximum recommended dose, whether in quantity or concentration. And you can also say that it's an excessive dose. So if you have something that speaks to this in your report, you can say, okay, for MedDRA purposes, this is an overdose. All right, so I want to take you back to the slides, and sorry we don't have the time today to do a full demo of the new WBB, but just last week, our colleague Jane Knight did present a webinar on the new WBB, and that presentation is available on our YouTube channel, so you can access it there if you're interested. Okay, a few advanced coding principles from the term selection PTC document. Let's talk about diagnosis and provisional diagnosis. If your report includes a definitive diagnosis without signs or symptoms, the only option here is to code the diagnosis. Whether it's a single or multiple diagnosis, it's the same approach. You code the diagnosis. A provisional diagnosis is when you have words in your verbatim that convey a diagnosis has not been confirmed. So think of words like suspicion of, probable, presumed, likely, rule out, questionable, differential, like these kind of words. In this case, the only option again is to code the provisional diagnosis as though it was confirmed because you have nothing else in your report. And again, whether it's a single or multiple provisional diagnosis, you code the provisional diagnosis. What about if the report does include signs and symptoms? Now, if the report is a definitive diagnosis with signs and symptoms, the preferred option, according to the PTC guideline, you only need to code the diagnosis. Of course, as long as, it's an important caveat, as long as the signs and symptoms are associated with this diagnosis. So the example here is if you have anaphylactic reaction, along with rash, dyspnea, which is shortness of breath, hypotension, and laryngospasm. If all these signs and symptoms are associated with the anaphylactic reaction, then all you need to code is the diagnosis of anaphylactic reaction. And laryngospasm, by the way, is when you feel your throat is closing up and you can't breathe. So it happens in anaphylactic reaction. So here, the preferred option, according to the PTC guideline, is only code the diagnosis because all of these signs and symptoms match this diagnosis, telling you that there was only one single medical event that happened here. But if the reporter is telling you that the diagnosis is not confirmed, so it's provisional, and they give you signs and symptoms, then according to the PTC guideline, the preferred option is to select the MedDRA LLT terms for the diagnosis as well as terms that represent the signs and symptoms. So if it's a provisional diagnosis and you have signs and symptoms, basically you're coding everything. Now, one great feature in the PTC guideline is that when there's more than one option for coding, they will give you their preferred option. They will identify their preferred option in the PTC document, but that does not limit you as a MedDRA user to apply that option. You do have the choice to follow the alternative option. So if we stay with the examples we shared, but this time we're showing you the alternative option. You see that for the diagnosis that had signs and symptoms, there is an alternative option that some folks do follow, which is to code everything. You code the diagnosis, you code all the signs and all the symptoms that you received. So there are colleagues that I know that follow this approach. Users should always first consider regional regulatory requirements. So depending on the region that you're working in, or you have colleagues in that region that you're sending data to, something to think about is what does the local regulator require? And an organization, like we said, should be consistent. Consistency is key. So as long as you are consistent in the option that you choose, you apply it consistently across your data, you'll be fine. You document it in your internal coding guidelines. Now, we said that the preferred option for provisional diagnosis with signs and symptoms is to select a term for everything. So you're coding the diagnosis, you're coding the signs and symptoms. But there is an alternative option. So when you have a provisional diagnosis that's not confirmed, and you have signs and symptoms that match that provisional diagnosis, the alternative option is only code your signs and symptoms because they're not going to change. The diagnosis, when it's provisional, may change, but not your signs and symptoms. So I hope this was clear, but if you have any questions, let me know. So in the example for provisional diagnosis, if they say there's a possible myocardial infarction, they had chest pain, dyspnea, diaphoresis where they're sweating, they all match the provisional diagnosis of myocardial infarction. If I'm following the preferred option, I'm coding everything. But if I'm following the alternative option, I just need to code for the signs and symptoms. So I'm coding chest pain, I'm coding the dyspnea and the diaphoresis. Now, in any of these scenarios, if you receive signs and symptoms that are not associated with your diagnosis or with your provisional diagnosis, then of course you do need to code these separately to the diagnosis. So if you have, for example, myocardial infarction with chest pain, dyspnea, diaphoresis, ECG changes, all of these so far are associated with the diagnosis of myocardial infarction. That's a single medical event that happened to this patient, but they also had jaundice. Jaundice is not typically associated with myocardial infarction. There could be a secondary underlying pathology happening here. So you don't want to miss that bit of information. So if you have any questions on this, please let us know in the chat and we can address them. But let's move on to an example. So in this particular example, it's saying that there was a sepsis leading to shock from possible spontaneous bacterial peritonitis or bowel perforation. So what you have here in this report are two provisional diagnoses. There was a possibility that the patient had spontaneous bacterial peritonitis or that they had bowel perforation. And the resultant complication of that was a sepsis leading to shock. So we said try to find a term in MedDRA that has all the details in the same LLT. So even though MedDRA has LLT for sepsis and a separate LLT for shock, MedDRA also has an LLT for septic shock. So in this particular example, the best approach would be to code the septic shock and code the two provisional diagnoses of spontaneous bacterial peritonitis as well as bowel perforation. Okay, what happens when you get conflicting information in your report? So that's really tough to code when you have conflicting, ambiguous, or vague information. And of course, the best approach is, can we ask for more clarity from the reporter? Can we ask them to specify the report? Well, if you have that option, that is the best approach to obtain more information. But if clarification can't be achieved, the PTC guideline does offer insight how to approach these scenarios. So here's an example. There's a report of a hyperkalemia with a serum potassium of 1.6 milliequivalent per liter. Now, if you look up a range for serum potassium with the units of milliequivalent per liter, you'll find that this is a low result. But the reporter is telling you they had hyperkalemia. So you're not sure which part of the report is the one that's not accurate. Did the patient have hyperkalemia, but the numeric result here is incorrect? Did the patient have the right numeric result, but they mixed it up and put hyper instead of hypo? We don't really know without eliciting further details from the reporter. So because we don't know, the best approach here is to just code it as serum potassium abnormal. We can't assume a medical condition of hyper or hypo, and we can't assume an elevated or decreased serum potassium. We just know something's going on with the potassium, so we can just code it as abnormal. And that covers both concepts, whether it's increased or decreased. For the GU pain, GU as an acronym is a ambiguous acronym because it can stand for genitourinary, it can stand for gastric ulcer. So we're not sure what's happening here, but we know there's some kind of pain. So the best approach here is not to make assumptions for this acronym unless we can elicit further details from the reporter. And in this particular example, we code the pain. What about vague information? So again, if you have vague information, try to obtain clarification if that's a possible option. If clarification can't be achieved, you can select an LLT that reflects the vague nature of the reported event. So look at the difference between the two examples you have on your screen. The one on top turned green doesn't give you any bit of detail. You don't even know whether this is something that the person experienced or whether this is something outside of the person. Did the pill turn green or the liquid turn green or something on the device got discolored, or was it the patient's skin or the patient's urine or the patient's hair? I mean, we don't really know what's going on here. We don't even know whether this is a medical uh, uh, condition or whether it's not a medical condition. So MedDRA does have LLTs that can cover these kind of scenarios. The best option here is unevaluable event. We know an event happened, something happened. We just don't know enough details to say whether or not it's a disorder. But if the reporter does tell us it is a disorder, it's just we don't know the details of the disorder. So something like the patient had a medical problem, but it's not clear what that medical problem was, then you choose something like ill-defined disorder, because that word disorder indicates that there's a medical pathology happening here. We just don't know what it is. So that's the difference between the two. And although I don't like to stop for questions when we're not yet at the halfway mark, but because these may be confusing, Hannah, any questions so far?
Yes, we've got two questions so far. One says, if your database can only code one term, how would you code all the signs and symptoms if the diagnosis is suspected?
So that's a good question, and there's no one answer for this. I mean, that's where your internal guidelines and internal decisions come at play. There are different approaches, different companies do it differently. You could, I'm just giving you examples here. So this is not, the go-to approach because it really depends on your internal decisions. So the way your database is set up, are you able to enhance terminology? So are you able to split them on your own and enhance terminologies? If not, are you able to query and request that the reporter split them and report them separately? So there's different ways of doing it, but again, it really depends on your database configuration and how your organization decides on the approach and whether or not you're able to communicate with the reporter to make any changes to the verbatim. What's your second question?
Perfect. The second question is, if initial case contains possible diagnosis and symptoms, we code all terms, but when follow-up confirms the diagnosis, should those symptoms then be removed from the case?
Another good question, and another one where I tell you it also depends on how your organization configures these updates. So, and again, I'm not giving you this as the go-to. These are just different ways of doing it. Some organizations would clarify with the site and then they modify the verbatim with the same start date and end date. Some organizations, they decide that now we put an end date to the previous report and we have a new start date with the diagnosis that it's been confirmed. So there's no one way to approach this. It really depends on your organization's approach, how you've been doing it before, and please always document these decisions and make sure they're applied consistently so that you show the thought process behind it. And it's always a good idea to have folks from different teams because then you'll be able to tell what the downstream effect is. So folks from analysis will tell you if you approach this alternative versus that, what the impact on data analysis will be. But all very good questions. Okay, so here's examples of things we just spoke about. Clinical complication of IUD. Now, IUD, you think intrauterine device, and this is a clear one, but it's not always the case. IUD can stand for different things. In pregnancy, it could be an intrauterine death. In urology, it could be intermittent, something with the bladder or with the diversion of the urine, or it could be different things. So you can't really assume that this is an IUD device, and you're not sure what it stands for. Not sure what it stands for, then you can't really tell if this is happening to the patient or this is happening to a device or if it's something else. So in the first example, the best approach would be to use the unevaluable event. We know something happened, we just don't know if it happened to the patient or outside of the patient. The second example, hypoglycemia with a blood glucose of 200 milligram per deciliter. So you have the unit here, and if you look it up, you'll see that this is really elevated sugar, but the term says hypoglycemia. So again, I'm not sure which part of the term is the one that's accurate and which part of the term is not correct. So my best approach here is just to say there was something going on abnormal with the blood glucose, but I can't tell unless, of course, I can elicit more information from the reporter. Okay, let's talk about investigations. So, of course, there is a system organ class for those of you familiar with MedDRA that is investigation SOC. It includes test names with qualifiers, not numeric qualifiers, but qualifiers like increased, decreased, abnormal, even normal, and investigations without qualifiers, so that you're able to code anything that was done to the subject, any lab work or x-rays or things like that that were done. Medical conditions corresponding to these investigations are in the disorder SOCs. So, like for example, metabolism and nutrition disorder is a disorder SOC. They tend to have terms like hyper and hypo. So these are medical disorders, they are diagnoses. The investigation SOC is not multi-axial, meaning that preferred terms that reside in the investigation SOC are only linked to the investigation SOC. It's really not possible sometimes to link one lab test to all the possible different system organ classes that could have been associated with that one lab test. So the investigation SOC is uniaxial. So it's always important to consider the terms in that SOC when you're thinking about data retrieval. But let's take a look at these two examples. So if your reporter says the patient had hypoglycemia, they're giving you a medical condition. So that needs to go to a disorder SOC. So that goes to the metabolism and nutrition disorder as the LLT hypoglycemia. If you have decreased glucose, and that's the extent of your report or your source, then that's a lab result. That's an investigation. It goes to glucose decreased. It's not a disorder. Okay, what happens if your investigation is ambiguous? So you have an investigation result and it's ambiguous. So if your reporter says glucose 40 milligram per deciliter, you know that this is below the reference range, so that's a low glucose. That's an investigation, it's clear. But what if they tell you the glucose was 40 and they don't give you a unit? Well, in this case, the reporter did not specify the unit, and that could be an issue because, some centers, they have their glucose in millimoles per liter, and in millimoles per liter, this is really high. So you don't really know. Are they telling you the glucose was high in, millimoles per liter, or was it low in milligrams per deciliter? So again, it's ambiguous. You can't make an assumption. So your best bet is to query the site. But if you can't get information, or the reporter, if you can't get information, then your best matching LLT is just to say glucose abnormal for this particular example. Now, what happens if you have an investigation with a diagnosis? If you have both together and the investigation result is consistent with your diagnosis, then you only need to select a term for the diagnosis. So elevated potassium, 7 millimole per liter, and hyperkalemia. Well, hyperkalemia is a diagnosis. It's a medical concept. and you expect that folks with hyperkalemia would have elevated potassium. So that is part and parcel of this diagnosis. You only need to select the hyperkalemia as the LLT. You don't need a separate LLT for the lab result. What about if they're grouped? What about if you have multiple lab results that are reported together? So you have increased alkaline phosphatase, SGPT, SGOT, and LDH. That was the way that you received your report. In this case, you have a lot of specific lab results that are being reported. So your best approach, and according to the PTC guideline, your best approach in this case is to select an LLT for each of these separate results. The guidelines tell you don't lump them together. Don't lump them as liver function tests abnormal. You only lump them if your reporter tells you these are liver tests abnormal. But if you have the specificity of all of these different lab results, according to the PTC guideline, this is a significant bit of information that you don't want to lose in one lumped report. Okay, so here's examples. If your reporter tells you that there was testing and they showed increased serum creatinine and BUN over creatinine ratio, so how would you approach this particular term? We just said that if you have separate lab results, the preferred option is to select the individual lab results separately. So you don't lump them in one term. But what about the second example? The patient had features of aldosterone excess. If the patient had features of this disease, this is a report that is describing a medical condition in a patient. So you're trying to look for something that reflects the medical condition in this patient. They already had features of this medical condition. So it's not a standalone lab result. So in this particular example, it's actually the aldosteronism that's the best match for this verbatim. Let's talk a little bit about combination terms. So a combination term in MedDRA is a single medical concept, is combined with additional medical wording that either provides important information on pathophysiology or etiology. A combination term is internationally recognized, distinct, robust medical concept. But when you think about things like arrhythmia due to atrial fibrillation, well, every atrial fibrillation is an arrhythmia. If you code this, then you're coding atrial fibrillation because that's the specific type of arrhythmia that the reporter is giving you. If you code both of them, then you are duplicating your adverse events. Why would you do that? Because you have the specific type of atrial fibrillation, of arrhythmia. The specific type is the atrial fibrillation, and that's what you code. Again, with hepatic function disorder, but the reporter put in parentheses acute hepatitis. Well, the acute hepatitis is a specific type of hepatic function disorder, so you want to be as specific as possible, and that's all you need to code. There are combination terms in MedDRA that can be reported together as a single concept. So, common examples are diabetic retinopathy. So if you have retinopathy due to diabetes, you don't need to split them. You have diabetic retinopathy. You have itchy rash. You have the HER2 positive breast cancer as a single LLT option in MedDRA. But not all combination terms, of course, exist in MedDRA. So when do you split? And when we talk about splitting, splitting means to use more than one LLT to convey the entirety of the information that you received in your report. So if splitting gives you more clinical information, more detailed information that you don't want to lose otherwise, then your approach would be to select more than one LLT. And going back to the question we just received, the mechanics of doing that depends on your organizational approach. But in order to capture the entirety of the term, the PTC guidelines tell you you need to select more than one LLT. So for example, diarrhea and vomiting, you don't have a diagnosis here. So your approach would be to select an LLT for diarrhea and a second one for vomiting. Risk factor and fall, that's the same approach. The BRAF positive malignant melanoma, that's the same approach, because in the field of oncology, there may be situations in which it's important to capture information not only for the tumor type, but also for any associated genetic marker or abnormality because of the implications for etiology, prognosis, or treatment. If a combination term that describes a genetic marker or abnormality associated with a medical condition is not available in MedDRA, you can select separate terms to represent these as well as the medical condition or the cancer. Just remember that medical judgment is needed when you're deciding whether or not to split and whether or not you could lose data if you don't split. And as a reminder, check the MedDRA hierarchy above the selected term just to be sure that it's appropriate for your reported information. So here's an example. Retinal disease from HIV with near total blindness, right and left. Now, HIV retinopathy is common in HIV. So retinopathy is one of the most common ocular complications of HIV. However, blindness is not typical in HIV retinopathy. So we are receiving more than one significant bit of information in this report. We do have the information that they had retinal disease, that they had HIV, and that they had total blindness in both eyes or near total blindness. So if I'm trying to find terms in MedDRA that can convey the most information that I have in my report, I'll be able to find HIV retinopathy, although I have HIV separate to retinal disease, but I have HIV retinopathy. So that's a good one that can collect parts of my report, but I also have the blindness for both eyes. So I don't want to lose that bit of information. I want to capture that. And the best way is to choose more than one LLT. Medication errors are a really, really interesting topic. We do have webinars that speak specifically to medication errors. You can find recordings on our YouTube channel from previously aired webinars on this topic. Now, per the PTC document, medication errors are defined as unintentional and preventable events. So they're unintentional and very importantly, they are preventable, which is why the regulators are really interested in medication errors because they do try hard to prevent them. Now, these medication errors can cause or lead to inappropriate medication use or patient harm while the medication is in the control either of the healthcare professional or the patient or consumer. So a few helpful hints with medication errors, because it's a very popular topic. Always reference the concept descriptions. Like we said, the concept descriptions, they're not that long, like they're under 90 terms, so it's kind of quick to go through. But you'll see how MedDRA classifies and uses the relevant descriptions. For example, misuse versus abuse, or overdose versus underdose. Another great resource for you is that companion document that we showed you in that blue ribbon underneath the other PTC guidelines. That companion document has really a large number of details and a huge number of examples with questions and answers on medication errors. And another good hint is when you're searching for LLTs to code medication errors and product issues, there's a nice grouping term, HLGT, called medication errors and other product use errors and issues, where it has a lot of different nuanced MedDRA LLTs that speak to many different types of medication errors. So if you're not sure how to code your report, or if you're not sure what the best LLT is, you can open up that HLGT and kind of drill down through it. It might take you some time the first couple of times, but then you'll start to see how they are being grouped in the respective HLTs and the many various different nuanced options that MedDRA has for this topic. But let's give a few examples on medication errors. So how do you approach medication error that is reported with a clinical consequence? Of course, you don't want to lose the clinical consequence. The clinical consequence is really important, but so is the medication error. The medication error is really important. If you're analyzing your data and you're finding a repetitive medication errors, then there are actions that you can take to prevent that from happening further. So the patient was administered the wrong drug and experienced hypotension. So this report is giving me two types of information. It's giving me a medication error that they received the wrong drug and a clinical consequence of the hypotension. And of course, it makes sense that the preferred option is to capture both of them. So you do capture LLT for the wrong drug administered, as well as an LLT for hypotension. Sometimes the report gives you a story. It gives you a lot of information that you need to kind of unpack and think through. So the second example we have here is a bit long. Because of similar sounding drug names, the wrong drug was dispensed. And as a result, the patient took the wrong drug and experienced a rash. So, okay, we do have a clinical consequence. We have the rash. We do know that that needs to be captured. But what else is this reporter telling us? They're kind of giving us really nice bits of information. They're telling us that there was a medication error because the wrong drug was dispensed. We consider this as an originating error. So it started with the wrong drug being dispensed, but they're giving us a bit more detail about that. They're telling us why this happened. There was a contributing factor to why this happened because there were similar sounding drug names. This is a really important bit of information when you're analyzing your products, when a regulator is looking at different products. Knowing that there are similar sounding drug names is really important because there's an action that can be taken here to prevent this happening in the future. So if your reporter is telling you that there was a wrong drug dispensed with a contributing factor, it is really important to select LLTs that represent both. So you have an LLT for wrong drug dispensed as your originating error. You have an LLT for wrong drug administered as your consequent error. And you have an LLT for your contributing factor, which is your drug name sound alike, in addition to your clinical consequence. And these kinds of examples is what you see in that companion document and in our webinars for medication errors. So here's another example. So insulin preparation was given using the wrong syringe. It resulted in the administration of an overdose, and the patient developed hypoglycemia. So again, the clinical consequence hypoglycemia is there. We do have the medication error that the drug was administered in the wrong device, an example of a nuanced LLT that gives you kind of nice, neat details. But what about the overdose? The reporter is telling us an overdose happened. So I can code the overdose. But you see here on your screen that we actually selected an LLT for accidental overdose, even though the original verbatim did not specify this was accidental. And in the PTC guideline, it does tell you that if in your context you can tell that this overdose was accidental, select the LLT accidental overdose. That LLT is really important for regulators. If they know that there was an accidental overdose, there's an important area here that maybe you need to step in and identify why it happened, especially if you see a large number of reports for accidental overdose that maybe can be prevented in the future. So what happens when you have medication errors without clinical consequence? So these are typically not adverse events or adverse reactions, but it is important to record the occurrence of a potential medication error, as well as a medication error that happened without a clinical consequence. So if you have a medication error without a clinical consequence, you have a preferred option, according to the PTC guideline, is to only select an LLT for what happened. What happened was the medication error. You didn't have an adverse effect, so you don't need to select an LLT for an adverse effect. But like we said before, the PTC guideline does allow for alternative approach. And you as a user, you're not tied to just following the preferred approach depending on your organization preferences as long as you are consistent. So consistency is always key. There are organizations where capturing the fact that there's no adverse effect is really important. So think, for example, poison control centers. If they report exposure, then part of their maybe protocol is to decide or click whether or not there was a clinical consequence. So for those kind of situations, capturing an LLT for no adverse effect is important. But in your clinical trials, for example, if there's no adverse effect, You don't want to have an AE that's an absent event. So you're not capturing an AE that's an absent event and adding, a number to your totality of your reports without having a report. So that's something to think about. Okay, what happened if there was no medication error, but a situation happened that could have led to a medication error? So nothing really happened. Nothing happened here. There was no medication error, but it was possible to have happened. So here's an example. The pharmacist notices the names of two drugs look similar. The pharmacist is concerned that this could result in someone getting a wrong drug. Why do you think this is important to capture? Why do you think this is important to code in MedDRA? Well, it's important to analyze. In these kind of situations, there is action that can be taken to prevent the possibility of the medication error happening. But you won't be able to get to that conclusion if you're not analyzing that data, and you can't analyze it without collecting that data. So if in the situation where you have a story or a scenario that a potential for a medication error was reported, you still need to report that, capture it, and code it. So this example is a potential medication error, and MedDRA has LLTs for potential for medication error. And sometimes they are specified, like in this example, there's a potential for medication error, wrong drug. But was there a contributing factor? So again, just like the medication error with a contributing factor, both are important bits of information. The potential for medication error with contributing factor, both are important bits of information. So a regulator looking at this with just the LLT that was a potential for medication error will tell you this is not reflective of the entirety of what the reporter says. The reporter gave us an important bit of information here, which is the contributing factor, that the drug names looked alike. And it is important to capture that when you're coding at the LLT level. Let's talk a little bit about overdose, toxicity, and poisoning. These are all important concepts, and they are important to be coded in MedDRA as long as they are explicitly mentioned in your report. So if you have an overdose with a clinical consequence, again, the clinical consequence is important to be captured separately. So stomach upset from a study drug overdose, you capture the stomach upset and you capture the overdose. There are qualifiers, there are qualified LLTs in MedDRA for overdose, but this particular report is not telling us whether this was an accidental overdose or it was an intentional overdose, and there's not enough context in here for me to say, oh, this was accidental. So I can't follow that guidance from the PTC guideline telling me if you have context, you can code the accidental, even if the word accidental is not in there. I just don't have enough in this example. The same with the other one. So the overdose without clinical consequence in this example, the patient received overdose of medicine without any adverse consequences. I don't know if this was intentional or accidental. I don't have enough context, so I can code only overdose. The alternative approach of adding a second LLT of no adverse effect is similar to what we said before. It's not the preferred option unless your organization chooses to collect things like absent events. No adverse effect in that case is available to you as an alternative approach in the PTC guideline. So let's see examples. So the patient's renal function was measured every 6 months instead of monthly schedule as recommended in the label for the drug. So when we look at this term, so what is this term telling us? I mean, I'm seeing examples here for monitoring errors. So what are monitoring errors, right? So monitoring or drug monitoring, it refers to surveillance of parameters which may be affected by the use of a drug. So common examples you think about are liver function tests, LFTs, renal function tests, blood cell counts. These are all common parameters used in surveillance or drug monitoring. When we see what happened with this patient, it's telling us that he was supposed to be getting these tests done every month. That's according to the label of the drug. But instead, their process was to do this every 6 months. So there is a error here in the way that the monitoring was being done. It's not that it wasn't done at all, it's just that it wasn't done correctly. So in this first example, the best option is that the monitoring procedure was incorrectly performed. Not that we're saying that the monitoring error as a standalone option was wrong, it's just that we have something more specific. We have an LLT that specifically captures this particular report. In the second example, so a patient unintentionally took more than the maximum recommended dose due to dispensing error. That sounds familiar, more than the maximum recommended dose. If you remember when we looked at our concept descriptions, that overdose was described in the concept descriptions as more than the maximum recommended dose. So even though in this particular example, I don't have specifically the word overdose, I can code in this example to overdose because the concept description tells me that if it's more than the maximum recommended dose, that's an overdose. Not only that, the PTC guideline tells me if my context supports the fact that this is accidental overdose, I can select that LLT. So the closest LLT to this scenario is the accidental overdose. And of course, I have the drug dispensing error. They're telling me something happened here. There was a medication error here. It was a drug dispensing error. Okay, let's talk a little bit about patient outcomes. Death, disability, hospitalization, they're all considered outcomes in the context of safety reporting. They're not usually considered adverse reactions or adverse events. And outcomes typically are recorded in a separate data field from the AE information. So if you receive a term that gives you an outcome with an AE, you don't really need to capture the outcome itself because the outcome itself is supposed to have its own data field. However, sometimes that outcome may be the only reported information, and in that case, you do want to code it. You don't want to lose that information. We have a lot of death terms in our general SOC. But sometimes the outcome, even though it is reported with clinical information, it gives you important details. So the example here is the patient experienced a rash and had sudden cardiac death. That outcome of sudden cardiac death is more than just standalone death. It's giving us a clinical bit of detail about that death. It's a specific kind of death. In this example, the rash is not expected to have been fatal. I mean, that's not an expectation for a rash to be fatal, unless, of course, it's some kind of manifestation of a serious condition, and you have a sudden cardiac death with a bit of more detail in that outcome. In this example, yes, you can select LLTs for the underlying adverse event of rash, as well as the clinically detailed type of death, which is the sudden cardiac death. So there are exceptions to, that approach in the PTC guideline that tells you don't capture the death in the LLT, except for the following examples, like we said. Interactions are tricky. Interactions are a little bit challenging because if you have a possible interaction, it could be between drugs and other drugs, it could be between drugs and food, drugs and devices, drugs and alcohol. In the PTC guidelines, they tell you that to select an LLT that tells you an interaction happened, you do need the reporter to specifically tell you. So you need that information from the reporter. It's really hard to assume when an interaction happened and when an interaction didn't happen. So in our example, the patient drank cranberry juice. The reporter is telling you that cranberry juice interacted with their anticoagulant and that caused an INR increase. Because the reporter told you there was a food interaction in this report, you can select an LLT for food interaction in addition to the resultant complication of it, which is the INR increased. But if the reporter does not specifically tell you that an interaction happened, it's really hard to make an assumption or make an inference. Or like if this same example, just told you that the patient drank cranberry juice, they were on an anticoagulant drug, and their INR increased. So the report is not saying that there's an interaction. They may be hinting it, but they're not saying that there was an interaction. You can't infer it. You cannot infer it. That's the PTC guideline approach. And remember, the PTC guideline was created by a working group that covers members from both the regulatory bodies as well as the industry. So the decisions that are displayed, or the recommendations, I should say, that are portrayed in the PTC guideline do reflect both parts of the industry. What about suicide? So when you have suicide in your report, there's different types of suicide. You could have it as a suicide attempt. You could have it as a self-harm term. You could have it as a completed suicide. So you want to be as accurate as possible to the reported term that you received without making any inferences or assumption. So if the motive for the reported injury is not clear, you can't assume this was a suicide attempt. So, if the patient came to you and the reporter said the patient sliced her wrist, you can't assume this was a suicide attempt. There was self-harm, but you can't make an assumption here that there was a motive behind it. If there was a suicide attempt, if there's no outcome reported with it, you can't assume that it was completed. If the verbatim tells you that the suicide attempt was fatal, then yes, you can select the LLT that says this was a completed suicide, and of course the death is still expected to be reported as a separate outcome in its own specific field. So here's an example: death from cerebral hemorrhage. The type of death is not specified. There's no additional clinical information in the word death. It is an outcome. I do expect to see it as an outcome, maybe a serious criteria, maybe a specific form that I have in my CRF capturing death detail, but I'm really interested in the cerebral hemorrhage because this part of the report is important to capture an LLT for. The outcome I can capture in its own specific field. What about this one? The patient was found dead. So yes, there's a death here, but there's a bit of information that is interesting because I don't know whether this was normal death or not normal death. I don't know if they died from natural causes or not, but I know they were found dead, and I have an LLT in MedDRA that specifically talks to this type of scenario. I have an LLT of found dead. Okay, after taking an antihistamine along with her prescription proton pump inhibitor, this 50-year-old woman developed vertigo. Okay, they're telling us that she took 2 types of medications and developed vertigo. I'm tempted to think that there was a drug-drug interaction here, but the reporter is not telling me that. And if you remember, the PTC guideline tells you don't make that assumption. So if I'm not going to make that assumption, the only thing I have left here in this report is the vertigo. Well, what about vertigo subjective? Subjective vertigo is when you feel that you're spinning, you feel your body is moving even though your body is not moving. It's a certain type of vertigo, but there's other types of vertigo, and like you feel the room is spinning, but not your body spinning. So it's a specific type of vertigo. I don't know what type of vertigo the reporter is telling me because it doesn't specify it. So in this report, the only information that can really assign an LLT to is the vertigo. What about this one? Deliberately took an overdose. So this is interesting because I have the specific type of overdose, which is deliberate. Well, what about intentional? Well, yes, they convey the same meaning as deliberate, but I'm trying to find words that match the source verbatim. So in this case, deliberate overdose is my best LLT. All right, so that was a lot of talking on my part, but we went through all the advanced coding concepts and how to approach them. Now comes the fun part of hands-on exercises. Again, this is the QR code. This is the URL to access it. But let's stop here for a few minutes, get a few questions in, and then, like we said, we'll open it up at the end for Q&A. But I do want to give you as much time as possible with these exercises because this is the most fun part of this presentation. Hannah, any questions?
Perfect. Our first question asks, in case of unevaluable event, should we consider the ICSR not valid even if an LLT can be coded?
That's such an interesting question. I mean, how would you say that ICSR is not valid? So the safety report was received, right? So there's something going on there. It's just that you couldn't find the best matching LLT. You can't really ignore that report because you received it, right? So you can't just ignore it completely because you received information from the reporter. Your best option, your best bet is to elicit more details. If you can't elicit more details, then you select the LLT that best matches the scenario according to the PTC guideline. And like we said, the PTC guideline was created with input from regulators. They don't want you to ignore these kind of vague or ambiguous terms. They're just giving you, here's an LLT you can select if you're not sure what the reporter means. So the first option is elicit more details. If you can't do that, look up that section in the PTC guidelines for term selection points to consider and see which of the LLTs best matches your scenario. But don't ignore it. It was information you received. Any other question?
Perfect. Our next question says, how would you address something like patient turned green? Is that an ill-defined disorder?
That's a good question too. Yes, because we do have discoloration terms in MedDRA that are specific to sites, right? So you have discoloration of skin, discoloration of bodily fluids, different kinds of bodily fluids, different parts of the body. So yes, if you have something where you can't really tell what they mean, did their tongue turn green? Did their skin turn green? Did their eyes turn green? So you're not sure what turned green? Yes, that would be a good option for you. Anything else?
Wonderful. Our next question is about if you could talk a little bit about split coding, something like acute respiratory viral infection. Do you split it into multiple parts? Do you try and code it as one singular code?
So that's a good question because, like we said, in the points to consider guidance, there are sections that speak to this kind of scenario. So if you have organism specific plus body specific term and you're not sure, so let me give you an example. Maybe we can do that and then we can um, move on to the exercises. So let me just walk you through here. So we said to get to the points to consider, we click the PTC, and here's your term selection points to consider. Here's your table of contents. So I'm looking for body site, location specific for versus microorganism, right? So if you have a term that gives you a microorganism plus a infection for a location, if you have both of them in your MedDRA browser, in your MedDRA files, you can select that, like the pneumococcal pneumonia. Well, what happens if you don't have a term in MedDRA that covers both, which is similar to the example that the user presented to us today? So here's an example, Klebsiella kidney infection. You don't have that as a term in MedDRA. What is the preferred option according to the PTC guideline? They're telling you don't lose the fact that there was a kidney infection and don't lose the fact that there was a Klebsiella infection. That's the preferred option. And like we said, this does not limit you as the MedDRA user to follow the preferred option. You can have a discussion internally. You can follow your own internal guidelines. Just document what the decision is and be consistent. Consistency is always, always key. So have those discussions internally, make a decision with your larger group, document that decision, ensure your team is all aware of that decision, and follow it consistently. So let's move on now to some hands-on exercises. I hope everybody is able to access the tool. And like we said, the QR code will be visible as we move forward. And just as a reminder, just when you see a term, think it through. What is the reporter giving you? How much information is a reporter giving you? Are there LLTs that capture most of the information in a single LLT? Do I need to select more than one LLT? And in the examples coming, we do share examples where you need to select more than one LLT. So for the folks online who are not used to selecting more than one LLT per verbatim, please, bear that in mind, that in these examples, we are going to give you examples where more than one could be correct. And let's start with the first one. Man with decreased fertility. Let me just make sure that I activate the polls so that you have it available to you. I see answers coming now. Okay, so man with decreased fertility. So which of these LLTs, and for these, for these hands-on exercises, we're going to offer you a collection of LLTs that you can look through and decide, but please also feel free to access the browser. Your temporary credentials are available to you in your chat. You can use your own organization credentials to access the browser if you wish to do so. I see a lot of answers came in, so let's see the responses. All right, very good. So the majority of you did find the LLT that captures the most of the information that we're getting. So the fertility decreased male combines both concepts, that there is a decreased fertility and I have the gender of the affected individual. Now, gender terms are not terms that are common in MedDRA, except where medically significant, like in this particular case. So the folks who picked the other options, please look through this, because if you have fertility decrease, that doesn't necessarily mean that they're infertile, right? So infertility means absolutely fertility is gone, but the reporter is not telling us that they are infertile. They're telling us that fertility was decreased, and that's a nuanced option in MedDRA. So please take a look at that and feel free to ask if you have questions about that. But very happy to see the majority with the correct one. So fertility male decreased. Let's do another one. Became colorblind in adolescence. How about this one? Became colorblind in adolescence. And I see responses coming in. Let's give it maybe a couple more seconds and then show responses. Maybe this is a good time to show responses. Let's see what responses look like here. All right, so this is a good one to go through maybe in the browser, the color blindness. Okay, let's do this. Let's go to the browser. I still have it open, but as a reminder, you go to your how to use, your tools, here's your browsers, and here's your new web-based browser. I still have mine open. So I'm going to go in here and I'm going to put COLO and blind. Now I'm going to hit enter. So I put COL and blind. And you see blindness color or color blindness. So you have these lexical variants where the order of the word shifts and the browser will look that for you. Incidentally, the browser looks for, the and functionality when it's looking up these terms. And like we said, root terms are very helpful for you. If you shorten a word and pick a root, it's helpful for you when you're looking. So what's the difference between color blindness standalone and color blindness acquired? Let's expand these and show the hierarchy for these two options. I want to show you something. Okay, so here's your LLT of color blindness, and you can see there's a PT of color blindness. And here's your LLT of color blindness acquired with your PT color blindness acquired. Now, the preferred term is a very important term. It's the level of MedDRA that usually is used for reporting. So when you're running your listings and your data output, you're seeing your preferred term. It's the one you use for reporting to regulatory agencies, and it's the one you use for analysis. So preferred term is very important. When you see LLTs going to different preferred terms, like in this example, these are separate preferred terms, that means they're significantly different. They are not the same medical concept. Why are they not the same medical concept? This preferred term of color blindness is linked to system organ classes. You see the eye disorders, but you also see congenital disorders with a blue box. A blue box means this is the primary system organ class, so that when you're outputting your data, your default setting, your default system organ class that's going to show up in your data is congenital. Now, why is that? Well, color blindness is typically a condition at birth, a condition that happens at birth. And in MedDRA, if you have conditions that can be both congenital and acquired, they have a convention in MedDRA. The more common form of the condition or the disease, that's represented at the PT level without a qualifier. Like here, color blindness is typically the more common form of the condition. You have it at birth. So it's typically congenital. You're born colorblind. So it doesn't have a qualifier. That's the more common form of the disease. The less common form of the disease is the one that's acquired. So it has a qualifier. And you'll see the difference in the hierarchy. The one that says acquired is only linked to a single system organ class, that's the eye disorders. So this is a really important example of why it's important to reference your hierarchy when you're looking up, how do I code this? Or am I reviewing these coded data and is this the right code for this? What's the hierarchy? If I chose, and let me go back to the results. If I chose that this was color blindness, standalone color blindness, then I am adding to my results, to my data, that this patient was born colorblind, because this is going to be my primary system organ class allocation. I'm assuming a congenital disorder. But that's not what the reporters telling me. The reporters say they became colorblind, and they became colorblind in adolescence. They are telling me that this was not something at birth. So I can't make that assumption that this was at birth and code it as a congenital disorder. I need to select acquired. Now, what about the difference between these two? Well, yes, we do have American spelling in MedDRA at the LLT level, as well as British spelling. And then we have British spelling at the PT level and higher, because MedDRA was originally a British product. So that's where that spelling came from. Or I should say it started based on a medical dictionary that was created by the predecessor of the MHRA, what we now call the MHRA. So that's why we have British spellings in MedDRA, or as you know, some folks in MedDRA say, the proper English spelling. But anyway, if the reporter uses the American spelling and I have it in my MedDRA files, I'm going to try to match it. If my reporter used a British spelling and I have it in my MedDRA files, I'm going to try to match the reporter. And that's all where that's coming from, why these two, but they go to the same preferred term. But even to that level of detail, and coders know this because coders tend to be really, really detailed individuals, even to that level of detail, you can find the best matched LLT. So in this particular example, my correct answer is the color blindness acquired with the American spelling, because that's what the reporter gave me. Here's another one. Turned very greasy. Turned very greasy. So remember what we talked about before. What is the reporter telling you? What happened here? Turned very greasy. Okay, we have about 60 responses, so let's pull it up now. All right, so the majority picked unevaluable event. And why is that? Because something happened. We just don't know whether it happened to the patient, whether it happened outside of the patient. What turned greasy? We don't know. Did their skin turn greasy? Did their hair turn greasy? Did the liquid that they're supposed to use for something or other turn greasy? Was it the product or is it the patient? We don't know. Well, what about this unevaluable reaction that some folks are thinking about? Why isn't that not the right one? Well, as a side note, unevaluable reaction in MedDRA also links to the same preferred term, unevaluable event, but it's really best as an LLT when your verbatim reports a reaction that can't be determined. So we don't have any indication in this particular report that there was a reaction. So because I don't have that kind of context in the verbatim, the best option here is unevaluable event. So let me just move on to the response. Unevaluable event as the majority selected. Very happy to see that. What about this one? Patient experienced a medical problem. So the patient experienced a medical problem. What is the best LLT that matches this scenario? Okay, I have a good number of responses. Let me open it up and see. So the majority, well, 50% are picking ill-defined disorder, but we are everywhere, right? We are everywhere in this. So let me just show you, where do these terms exist? So unevaluable, we said unevaluable events and ill-defined disorder. If I want to look at surrounding terms, if I'm trying to pick a term in MedDRA and I'm not sure which is the right, is it the best matching one? Is it not the best matching one? One thing I can do is I can right click and try it on your side. It's really nice. You can right click a term that you found in your search, and then you can go to browser. Basically, you're telling the tool, take me to where this particular term resides within the MedDRA files, and I want to see the surrounding events. So it'll take you to this particular term, and you can see there's a long list of terms that are available in the same HLT. Here's my term, and as I was scrolling through it, it all exists under the same HLT. You see it under the HLT, General Signs and Symptoms, in my journal SOC. What about my adverse event? Where does that reside? So in the same SOC, but under a different HLGT, I see therapeutic and non-therapeutic effects. And if I open this up for therapeutic and non-therapeutic responses, that's where I see my adverse event. I also see adverse drug reaction. So those in the pharmacovigilance field, you know that these kind of words matter. Words do matter in these kind of definitions. An adverse event is any untoward, right? Untoward medical occurrence. We all had that training in pharmacovigilance. It happens in a patient or clinical investigation subject who were administered a product. So there is the adverse event itself, even if the patient signed the informed consent and started going through the trial. So in clinical trial settings, after you sign informed consent, you start collecting adverse events. But there is eventually going to be a product or interventions happening to that patient when certain lab results or x-rays or whatever are done as part of that protocol. So these are adverse events. They are happening in a patient or a subject who are part of either a protocol or they are being administered a product, whether or not it's causal, right? Because the adverse reaction is the one where causality is at play. But when I go back to my verbatim, I'm going back to my verbatim here. The patient experienced a medical problem. They're not telling me this patient was part of a clinical study and it was after informed consent. Of course, unless that is basically what you are collecting. So if you are collecting information and that information is specified to patients who belong to a particular clinical trial and they've already signed your informed consent and this is your adverse event, then yes, in that particular scenario, you can code the LLT adverse event. And that's where the confusion comes here for. But because we are a larger group, we are not assuming this is a clinical trial setting. This is just a report. This could be post-marketing. This could be somebody calling their own physician and talking about, I took this and I don't like it at all. Something happened and I'm not happy, but they don't tell them what. So we can't make the assumption that this happened in the setting that matches an adverse event. We also can't say this is an evaluable event because we know it's a disorder. It happened to a patient. We know this is a medical condition that happened to a patient. So in this particular example, your best choice for an LLT would be the ill-defined disorder. Something medical is happening. Something medical is happening to this particular person, but we don't know the details enough to say what. So we can't say unevaluable event or unevaluable reaction. We can't say adverse event, not in this setting, because we're not specifically targeting settings where we have the conditions that meet an adverse event definition. So the best option here is the LLT, ill-defined disorder. Here's more examples. There's a 2-year-old that accidentally took their mom's medication. Okay, so the 2-year-old accidentally took his mom's medication. Do we have an LLT that captures as much as possible of the reporter details as we can find? Do we need to select more than one? Let's see, we're almost at 60. I think at 60 is a good time to show. Okay, even more. Okay, so the 2-year-old accidentally took his mom's medication, and I see the majority going for the accidental drug intake by child, which is really good. So what's the difference here? What are the nuanced differences between these? If I say there was an accidental exposure to the product by the child, this is not enough because I know that the child took it. They did take this medication. So they were not just exposed to it, they actually took it. And that's an important bit of differentiation between someone just grabbing the medication and someone swallowing the medication. The verbatim doesn't use the word ingest, so I'm going to do intake because that's closer to the verbatim. And it is specified in the verbatim as a medication or a drug, which is why it's more specific as accidental drug intake than product intake. But if I'm not sure if it's a drug or if it's something else and it's just a product, or the verbatim tells me product, then I can do the first one. So very happy to see the results here. And yes, you guys are correct. It is accidental drug intake by child. Okay, let's do another one. Infection after surgery. So infection after surgery, which is the LLT that best reflects this verbatim and the closest possible match to the reporter words. Remember, we try to be as close as possible to the reporter words. So we have enough responses. Let's see what it looks like. And yes, the example here is post-operative infection. So why are we not selecting post-operative wound infection or surgical wound infection? Because we don't have details that say this happened at a wound in the verbatim. We know that there was infection. We know it happened after surgery. There is no mention of the word wound in the verbatim, so that would not be the best match. So let's see the correct answer is a post-operative infection. Very happy to see that. Good job, guys. Okay, this is a tricky one. He sold his father's medication. He sold his father's medication. We are giving you options. One of them is the option that we are shooting for. And there is a lesson behind the slide. So he sold his father's medication. Let's go through a few more seconds just to get a good number of folks taking a look at this example. Okay, we have enough here, so let's show responses. All right, this is really interesting. We're kind of split. A lot of people go with drug diversion, and there's a good number of people who are saying this is intentional drug misuse. So let's go to our trusted concept descriptions. Here's my concept descriptions. Let me look at misuse. How is misuse described for MedDRA coding purposes? Misuse is, first of all, intentional use. Second of all, it's intended for a therapeutic purpose, either by a patient or consumer of a product. And that use is not in accordance with the product information. So the key word here is that it's intentional use, but they intended it for a therapeutic purpose. So let's say that the doctor prescribed a dose at 1 pill every 6 hours, and you're not getting benefit from it. So you're not following the product information, and you took 2 or 3. You took it intentionally because you want to try to feel better. But the reason you took it is because you want to try to feel better. That's a therapeutic purpose. If you look at your verbatim in this example, he sold his father's medication. There's no mention that this was done for a therapeutic purpose. So it's not misuse at all. It's not a misuse type of term. He just sold his dad's medication. We don't even know if this is going to be used as a medication or for any illegal or illicit purposes. But what is this drug diversion? Is this in my MedDRA concept descriptions? Let's take a look. Let's take a look. So if I go to the D's and I go through drug diversion, I see that it is mentioned here. So I hope it's clear for you. So drug diversion basically means that a drug is diverted from legal and medically necessary uses, like his father's medication was supposed to be used for, towards illegal uses. It's not legal to sell somebody else's prescription medication. That's not legal. So basically, we don't know the intent of why he sold it. Did he sell it to somebody else who has the same disease as their dad, but they don't have insurance? We don't know. The reporter is not telling us any details. The only known information is that he sold it. So we know it's not a misuse, so the last option is not correct. And we know it's a diversion based on the verbatim. So in this particular example, the correct LLT would be the drug diversion. Just an example here to show you how the concept descriptions can be a good resource for you. Okay, let's do this one. They had MI. Okay, how would you approach this particular verbatim? If all you have in your report is had MI, what would you do with this one? Okay, we have enough responses, so let's show. I'm very happy to see this responses. Yes, the majority of you are correct. Why is this an unevaluable event? Well, we'll show you. Let's show you in the WBB. If I just put in MI and I hit enter, it's going to take a bit of time because those are just 2 letters in the English language. So you're going to have a ton of results. You'll see almost 4,000. For those of you familiar with the previous web-based browser, this is a new improved feature because if you put in MI, maybe it's good to show you. If I go to the older browser and I put in MI, it's going to tell me there's too many results to display. Well, the new and improved web-based browser actually doesn't tell you there's too many to show you, but why would you just do 2 letters? But the good news is that they found an exact match. So you have an exact match with MI with the big red box around it. And remember, a big red box around the LLT means it's non-current. And non-current means it's there for legacy purposes, but don't use it for coding. Why you don't use it for coding is ambiguous. It's ambiguous. You can't really tell what MI stands for. It could be mitral infarction, myocardial infarction. It could be mitral incompetence, depending on what field you're working in. So it is an unevaluable event because I don't know what they're talking about. There's no information here enough for me to say what this MI stands for. So yes, thank you for that. The majority of you are correct. It is an unevaluable event. Let's do more. Okay, we saw examples of this in our previous slides. Hypernatremia with a serum sodium of 115 milliequivalents per liter. And if you want to look it up, or if you, as an FYI, you can look it up for serum sodium, in the milliequivalent per liter units. You have the units, it's about 135 to 145. So what do you have here? You have hypernatremia with serum sodium 115. You have enough responses. Let's see the majority. Yes, I'm very happy to see the majority have it correct. You have a condition of hypernatremia, but it's associated with a lab finding where the sodium is low. So one of these two is wrong. We don't know which one is the right bit of the information, which one is the wrong bit of information. I can't assume that just because this is outside the parentheses, that that's correct, and whatever's inside the parentheses is wrong. I'm making an assumption here. I have to go by what the reporter said. The reporter is giving me two conflicting bits of information. I don't know which one of the two bits of information is the right one. All I can say is that something's going on with the serum sodium. So is serum sodium abnormal, unless I can query for more details. So in this example, yes, the serum sodium is abnormal. All right, let's do a couple more. She accidentally missed the morning dose. She accidentally missed the morning dose. What do you guys think about this one? So a couple more seconds. Let's reach over 60 and then we can show responses. Okay, so missed dose in error seems to be the major one. Yes, I agree with you completely, because the reporter says she accidentally missed the morning dose. So I know that was accidental. It's not a standalone missed dose. I have something a bit more specific. Not that the missed dose is completely wrong. We're just saying that there are LLTs with nuanced details in them that give you even a better match to your verbatim. And that's why the missed dose and error is the good one. Well, what about this temporary interruption of therapy? This is an example where that document, the companion document that we showed you, it comes in handy because it gives you nuances of, well, what do they mean by temporary interruption of therapy? And if you look at that temporary interruption in the companion documents, you'll see it talks about external factors causing the interruption. Like, for example, the patient couldn't afford the medication, so they stopped for a while. That's a temporary interruption of therapy. So I'm glad to see these responses, and the majority of you are correct. Missed dose and error, so thank you for that. Let's do more. The doctor mistakenly prescribed the wrong drug. The pharmacist noticed the error, did not dispense the drug. Wow, a lot of information you're getting in this one. So the doctor mistakenly prescribed the wrong drug, but the pharmacist noticed and did not dispense the drug. Was there a medication error here? And if so, what kind of medication error? So this is an interesting example. Let's see the responses. Yes, I'm very happy to see this. So the word intercept means that it was stopped from reaching the patient, right? So it was stopped from reaching the patient. But at what level did this happen? So that the error that happened occurred at the prescribing phase. So I'm very happy to see that you guys have a good hold on this one. The doctor made the mistake during the prescription. So it was a prescribing phase error, but the pharmacist caught it and it became intercepted. So in the points to consider documents and in the companion document, they do talk about intercepted error terms where it should reflect the stage at which the error occurred, not the stage at which it was intercepted. So I'm very happy to see this response. You guys are doing really, really good. Very good. All right, how about this one? The patient reported a loss of smell and thought he might have COVID-19. He might have COVID-19. So remember, we talked about diagnoses and provisional diagnoses. What would you select in this particular example? Okay, let's show responses. All right, so I see the loss of smell. Yes, it is a sign or symptom, and I see the provisional diagnosis of a suspected COVID-19. So in this particular example, like we said, when you have a provisional diagnosis and you have signs and symptoms, you code both of them. You code the signs and symptoms and you code the provisional diagnosis. The anosmia, even though it means the same thing as loss of smell, so for those of you with medical information on the line and that you chose anosmia, the reason why loss of smell, even though they go to the same preferred term, it's a closer match to the verbatim. So that's why the LLT loss of smell would be a better option than anosmia. Okay, here's another one. The dose taken was below the minimum recommended dose in the product label. Sounds familiar. The dose taken was below the minimum recommended dose in the product label. How would you approach this one? Okay, couple more seconds. We'll reach 60 and then I'll open it up. Okay, let's take a look. Underdose, that's very good because, like we said, the concept descriptions are your friends. Concept descriptions will give you really nice hints about how MedDRA approaches these terms. We saw overdose as above recommended dose. Underdose is below recommended dose, minimum recommended dose. So this is very nice. We can't assume it's accidental. We don't have enough information in the verbatim to specify that this was intentional or accidental. We just know that this was an underdose. Okay, here's another one. Getting a bit more detailed in these reports now because his package of medication contained too much drug. So the patient received an overdose and developed nausea and then was diagnosed with gastritis. So you have a lot of information, and this is typical for some reports. Sometimes you have a good number of information coming to you in your reports, and you need to think, am I capturing everything in a single LLT? If not, then how many LLTs do I need, and what kind of detail do I have? Let's see responses. All right. We have a lot of information here to digest. Let's talk this through. Let's unpack this verbatim. So they're telling us that an overdose happened to this patient. And they're explaining the context of how this overdose happened. His package of medication contained too much drug, so the patient received an overdose. And remember, the PTC guideline tells you if you have enough context in your report that specifies whether or not the overdose was accidental, you can use that accidental overdose. In this particular example, I do have enough details telling me why the overdose happened. So it's not intentional and it's not just a standalone overdose. I have enough information in my context to say this was accidental. So I can select an accidental overdose. I have a contributing factor to why the overdose happened. His package of medication contained too much drug. You're not going to see information like contained too much drug in your MedDRA when you look in the browser, but there is a package volume overfill, which is a similar concept. So yes, I can choose that one. Well, what about the nausea and the gastritis? I see a sign and symptom, and I see a diagnosis in the same report. And remember the preferred option, when the sign and symptom are consistent with the diagnosis, I don't need to capture the nausea separately. I already have the gastritis, and nausea is a common sign and symptom with gastritis. So what does that mean? What is the eventuality of the information I'm capturing in LLTs here? I'm capturing the gastritis, not the nausea, because it's part and parcel. It's a sign and symptom that's associated with this diagnosis. I'm capturing the overdose as accidental, even though the verbatim didn't say that, because I have enough context in my report to deduce this was accidental. This is not a common thing. We don't like deductions and inferences when we're coding. But because this is an accidental overdose, which is a really important topic, the PTC working group did introduce that guidance in the PTC guideline. And I have the contributing factor that led to that overdose, which is the package volume overfill. So all of these bits of information are important, and I can capture them in separate LLTs. We're going to do a couple more. I don't know if we'll have time to finish all of the examples, but let's do a couple more. So she was abused by her husband. Which of the optional LLTs you see before you do you think is the best match for this particular term? Let's show responses. Yes, so this is really good. So the verbatim doesn't specify if this was verbal abuse or physical abuse or financial abuse or any kind of abuse. We know she was abused by her husband. And if you look up spousal abuse in your web-based browser, you're going to see it has a different hierarchy than victim of spousal abuse. Spousal abuse goes to the HLT criminal activity. We're talking about a victim of abuse here. So yes, the best match is the victim of abuse. So something to think about when you're coding abuse terms. Were they a victim or a perpetrator? So good. Victim of spousal abuse is the correct one. How about this one? The patient created a false belief that her relatives were stealing from her. What about this one? She created a false belief that her relatives were stealing from her. And this is kind of a symptom that is not uncommon in dementia patients. They have these false beliefs of different things. So let's see your response. Delusion of theft is really good. This is very good. We're matching the verbatim, right? So there was no real crime committed here. The report doesn't tell us that a crime was committed here. So I'm very happy to see this. Very good, guys. It is the correct option, delusion of theft. Maybe I'll do two more and then we'll open up for question and answer. Okay, the patient was treated with drug Z for rosacea, which is an off-label use of this medication, and developed dizziness. So what do you guys think? Okay, she was treated with drug Z, so let's look at responses. All right, so the dizziness is there. I see it. That's very good. I do see that the off-label use in unapproved indication, that's also good. But what about the rosacea? Not a lot of people are going for the rosacea. Well, if she was treated for drug Z as an indication, MedDRA can be used to code indications. If this is all the report you received, then why are you not capturing the rosacea? This is something happening with this patient. If you argue that I'm not capturing this because it must be on her medical history somewhere, then you have a point. But we don't know this is the case. This is not the setting of a clinical trial where you're capturing medical history. This is a setting of somebody talking to a reporter, and this is the full report. So don't make assumptions unless you have your coding in a specific scenario where you have set up parameters that can help you explain why you omitted the rosacea. But in this particular example, the rosacea is part of what you are expected to capture. Okay, so let me wrap up with a few coding pearls. Like we said, MedDRA is scoped for a wide variety of information, whether it is an indication, an adverse event, medical history, even social circumstances, a procedure or a procedural complication. MedDRA is scoped for all of these type of scenarios. We try to match the reporter's actual words as best as possible, knowing that MedDRA has specificity in some LLTs, so look for the LLT that is most specific and closely matched to your verbatim. Exploit the hierarchy. Always check your hierarchy. It's a very good idea to either right-click a term and look for the surrounding terms, like we did in an earlier slide, and also the placement of that LLT, like in that color blindness. Make sure that you're not making an assumption and taking that term to a SOC that you didn't expect that you were coding to. So follow the hierarchy. You can do a top down search, like we said with medication errors, that's very useful. A bottom up, like we said, when you click the LLT and you follow it all the way up to the SOC. And of course, you use your resources. You use your concept descriptions. That's a huge resource, but also you can use medical dictionaries, online searches, and the Boolean search terms. These are just how to do specific filtering and testing. So if we go by advanced search, so if we have the advanced search and we just to show you the advanced search, you can put begins with. So if you search for something and MedDRA just gave you thousands of results, you can say, I want it to be an exact match. Like this MI. If I say MI an exact match, it's going to give me an exact match rather than almost 4,000 results. That's a huge filtering for me. So very helpful. But it can also tell you, like, I want it to start with this particular word. I want to add that it contains another word, and so on and so forth. If I'm receiving too many results when I'm searching, I can introduce these Boolean options that are really helpful. And of course, training. So the last thing I'm going to show you on our website is that we are very happy to have released our learning management system. So if you go to our homepage, on that top right corner, you see the LMS, Learning Management System, and you have options of taking your own self-paced training and getting certificates for them. Or if you don't need certificates, just taking the training. But for the certificate track, you can get certificates to Introduction to MedDRA, Basics in Coding, or Advanced Coding. So if that suits your schedule better, rather than signing up for webinars, you have that option. All right, so we went over the advanced principles in the PTC document. We showed you the MedDRA concept descriptions and how they're helpful. We went through a lot of examples and hands-on exercises and ended up with coding pearls. There's a lot of references here in the slides for you as resources. Please feel free to use them. And I'm going to open up to Q&A, but I know we're at the top of the hour. So if we don't get to your question, I'm happy to stay on. And if you can't stay on, you can send us your questions to our help desk and we'll respond by email. Okay, Hannah, do we have any questions?
Wonderful. The first question is, what if the overdose was not accidental? If the patient is taking doses to make up for missed doses, how would you approach that?
So taking more doses to make up for missed doses is not necessarily an overdose. We said an overdose is described in the concept descriptions that it is more than the maximum recommended dose. So just having the patient taking additional tablets or additional, however the format of the product is, does not mean that this is an overdose. We selected overdose when the verbatim said it was more than the maximum recommended dose. But if you have additional tablets, there are other LLTs in MedDRA. If you have additional tablets taken, or the dose was higher than expected, we have LLTs that speak to that. So I would caution you against assuming an overdose when it's not really meeting the definition per the concept description.
Great. Our next question says, how do you approach it if addiction is explicitly reported in a medication error report?
You do have terms for addiction in MedDRA. So if you look up addiction and you see the different options, you do have terms for that. So you're welcome to browse the MedDRA files and see the best match to your verbatim.
Our next question says, in cases with described polypharmacy, interactions are very possible to happen. How do we approach coding that?
So I can only share with you what the guidance from the PTC guidance document states on interaction. Interaction can occur in different, uh, in different formats, not just drug and drug, drug and product, drug and device. Um, so it's the guidance from the PTC working group is that if the reporter tells you an interaction happens, you code the interaction. If the reporter does not tell you that, you cannot assume interaction. That's a tricky thing to assume and use in your reporting. If you have an organization specific approach that you think works for you, then please document it, like we said. Make sure it's consistently applied because that's key. And then you'll be transparent to any regulator when you're submitting your data. Anything else?
Fantastic. The next question says, when a drug causes an ADR and the ADR then degenerates into other problems that are not in fact related to the drug, how do you address coding that?
So that's not really a coding question because you're talking about an adverse drug reaction, and because it's an adverse drug reaction, then it reflects causality, temporality, and so on and so forth. MedDRA does not really reflect causality. Causality is not within the scope of MedDRA. MedDRA reflects the verbatims, right? So your verbatims. If your ADR resulted in additional complications and your approach as a company is to code everything and you want to capture that with different start dates and end dates and capture everything, that's perfectly fine. Whether or not it's causal to the product is not going to change really the LLT that you choose depending on your setup. Because I know we said, for example, unevaluable reaction and unevaluable event differ based on the verbatim because when do you use the word reaction versus the word event? And these are really nuanced approaches that can't be generalized. So you have to be careful the way you approach your data, talk it through internally with your team, and see your best approach. But causality itself is not typically scoped within MedDRA.
Perfect. I will go to the next one, which asks if we could revisit the question dealing with diversion, the example you gave.
Okay, so it's not a fair example because it was intended to showcase the concept description, but let me see if I can find that slide um, and what number it was. Sorry, let me just look through. Uh, it was the drug diversion that he sold his father's medication.
Yes, and they send a follow-up of you don't know how the potential buyer would intend to use it.
Of course not. Yeah, the
Yeah.
verbatim is basically that he sold his dad's medication. If the reporter continued to tell you the details of that transaction and what the intended use was and whether it was therapeutic, but whether it was, I mean, it's hard to go through that. But the bottom line is he sold his father's medication. This was a legal act with a product. So this was diverting the use of it from his father's using it for whatever condition that his father had to being sold. So that alone in itself is a drug diversion. Any other questions?
Our next question asks, can you please explain primary and secondary SOX?
Okay, I mean this is I'll give you an overview, but this is also covered in more detail in our basics MedDRA basics webinars. But in MedDRA, the way that the hierarchy is created, there are 5 levels of hierarchy in MedDRA. You approach coding by the LLT level. That's the lowest level term. It's the closest matching term to your verbatim. And then you go into the hierarchy. Every LLT is only connected to one preferred term, but then the preferred term itself, depending on the nature of that preferred term, can be connected to more than one system organ class. Now, there are rules for MedDRA to say, which system organ class the preferred term will connect to. And the general rule will tell you it connects to the system organ class where the primary manifestation occurred. So, for example, if your verbatim is a gastrointestinal sign or symptom, then you want to connect it to the gastrointestinal system organ class. If it's respiratory, to the respiratory, and so on and so forth. Well, what about something like dyspnea? Dyspnea is shortness of breath. So it is a respiratory manifestation. It happens in the lungs. It's a respiratory manifestation. But dyspnea is strongly linked to cardiac disorders. So in this particular example, when you have dyspnea, you don't want to limit yourself only to the respiratory system organ class. You also want to create a path for dyspnea to be connected to the cardiovascular disorder. So let's go back to basic and let's look at dyspnea. And let me just close this one and let me see if, okay, so dyspnea. When you expand dyspnea, you're going to see two HLTs under the PT. You notice that the LLT is only connected to one PT, and then the PT expands to more than one pathway. And you'll see that the primary system organ class is the site of manifestation. It is a respiratory manifestation, dyspnea, because it happens in the lungs, but it's strongly linked to cardiac disorders. So we create a secondary system organ class for dyspnea, and many other terms. Not every single term in MedDRA, but many terms in MedDRA can be connected to more than one system organ class. The really beneficial part of this hierarchy is that you can, as an end user in MedDRA, standardize your output so that everybody has the same standardization. So it is a true standardization globally, because when you output your results, you're always showing your primary system organ class. However, you can investigate your data and interrogate your data using the secondary system organ class based on your area of interest. And we talk about this in more details, both in the basic coding webinars as well as the data retrieval and analysis webinars. And it's included in our documents about MedDRA. So very good question, but I'm sorry I can't go into a whole lot more detail because it will take us down an extensive topic, and multi-axiality in MedDRA is a bit of a confusing topic. But feel free to reference our MedDRA guides. Let me show you where they are. They will give you good details on this issue. So let me just go to MedDRA website, and under PTC, you'll also see introductory guide to MedDRA that talks about multi-axiality. So if you're interested in that, also reference this as a good resource for you. Anything else?
Fantastic. The next question is about coding results versus symptoms. If you do a hypersensitivity test and the result is positive and you see redness and hypersensitivity, do you include those as well in your coding, or do you just do the test result?
So I'm not sure I'm quite understanding the test results, but if you have a test result that is consistent with a diagnosis, or if you have signs and symptoms that are consistent with a diagnosis, and you have the diagnosis, then the preferred option in the points to consider is to code only the diagnosis, because you only have a single medical condition happening here. You don't need to double count your adverse events. You don't need to double count them if you have a single medical condition happening. But if you have signs and symptoms that are not consistent with the diagnosis, or a result that is not consistent with a diagnosis, or you don't have the diagnosis in your verbatim, that's a different matter. So I hope I answered your question, but if it's not clear, please come back to us with a bit more detail. Anything else?
For drug interaction, should it be coded only when specifically stated by the reporter? We should not code the interaction if it's not reported, even if the interaction between the drugs is specified in the RSI.
Well, if you're saying that the interaction is specified, then how is it not reported? I mean, if your reporter tells you that they took two different kinds of medications and that the interaction occurred between them with a sequelae, then you have the information you need to code the drug interaction. But when your reporter just tells you that she's on a particular medication, she drank something or ate something, and now this happened, even the reporter is not sure that an interaction happened. They're not reporting that. So why would you code it? It's not being reported. Don't code it. I mean, one of the staples of coding in MedDRA is code what you have. Code what you have from the reporter. Let the verbatim drives your coding. Don't add information and don't remove information. Code what you received. And that's especially true for interactions. There is a section on interactions in the points to consider term selection document, so please take a look at that. Hopefully it has a bit more detail that will answer your question. Anything else?
Wonderful. Let me go to the next question. How would you address something like he hanged himself? Do you jump to suicide as the coder, or do you talk about self-injury?
Well, like we said, we don't want to assume intention, right? We don't want to assume intention. I mean, there are different things that you can think through as well. Could it have been a freak accident? Was there some kind of a sexual exploitation or a adventure? Was this as a dare to do something, but he did not have any intention of hanging himself? So it's hard to make assumptions for intentionality. Intentionality is not within the scope of MedDRA. If all the information you have is that he hanged himself and it resulted in self-injury, then you have self-injury, but you can't really assume the intent behind it. Same with, like, you can't assume this was a suicide attempt. You don't know what the patient was intending to do. So again, stick with the verbatim. If you can elicit more details from the reporter, then do that. But in the meantime, don't add assumptions from your end. Don't deduct information from the verbatim.
Our next question is another medication errors question. If a drug was prescribed off-label, but the physician does not report it as off-label, what is your recommendation?
That's a very common question, and there is mention in the companion documents specific to that. The expert working group hesitates about assuming off-label use. Off-label use is one of those things that if you don't have it from your reporter, you don't really want to code it. And they even say that specifically in the guidance document. So feel free to please refer to the points to consider document as well as the companion document on off-label use sections. Their thinking is that if the reporter does not specify that this was intended as an off-label use, we can't infer it when we code. But it is a common question, so thank you for raising it. Anything else?
Wonderful. The next question is about how important is acute? If you get that in the verbatim and you find a good LLT, but it misses acute, how important is that?
Yeah, well, acute, chronic, and subacute do have their place in the concept descriptions, but they're not qualifiers that are provided in MedDRA for every single term. So if you have a term that is either acute or chronic and you don't have that qualifier in MedDRA, you can select to use the unqualified term because MedDRA doesn't really go into a lot of these qualifiers. So, like if you think mild and severe, it's kind of similar as well. So if you have something that said this was a severe case of constipation, we don't have severe descriptors for all the options in MedDRA. So yes, there are descriptors that are not going to be available for every single term or concept that you have, but don't omit the event. The event itself is very important. If you have the acute describer, that's fine. If you don't have it, don't forget the event itself is important. Anything else?
All right. Our next question asks, I would like to ask about pregnancy maternal exposures. If upon follow-up abortion is reported, should case be updated with abortion or would a new case be more appropriate? Is this something company specific?
Well, yes, you're talking about the outcome of pregnancies, and depending on what kind of data that you're receiving, if this patient was part of a clinical trial, if this patient was not part of the clinical trial. So yes, it depends on the context of your report and what your guidelines are for capturing the information. It's definitely important to capture the abortion and all the details of the abortion, and but how to split it, which reports, what forms you need to fill, it really depends on the context of the receipt. So yes, please refer internally for that.
Wonderful. Um, Off-label for itself means using drug in unapproved indication. Why are there different terms, off-label use and off-label use in unapproved indication?
So sometimes you don't have the indication for the off-label. Sometimes you just say that the product was used as off-label. So it depends on how much detail you have in the report. You can see nuanced LLTs that offer you different options to match as close as possible to the original verbatim. And that's true for different kinds of LLTs in MedDRA. So when you're looking at your report, just ask yourself, how much detail am I getting? And is there an LLT that has this level of specificity, these level of specifics in it or not? Anything else?
Wonderful. There is a question about navigating the hierarchy in the browser. I would recommend looking at the browser demo. Would you agree, Suzanne?
What was the question?
It's about navigating the browser to view the hierarchy.
Well, let me show you real quick. And yes, you can look up online. So if you're, for example, this dyspnea, if you just want to see a short synopsis of the dyspnea rather than the plus 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 and open it up, you can right click and you can see open details and occurrences. When you do that, it opens up a new panel on your right hand side that shows you the full hierarchy. So rather than just clicking the pluses, you have the option to right click and select the details and occurrences, and it gives you a whole bunch of details about the hierarchy, whether this term exists in SMQs, and if so, what they are, whether this term exists in mappings, and if so, to which terminology and which code in that terminology. Or you can right click. Well, let me just right click and go to browser, and then the browser will ask you if it's more than one system organ class, under which part of the hierarchy do you want to see the details. And I want to see it under, for example, the secondary SOC. I want to see it in the cardiac. It opens up the left side panel of the browser with all the details of that particular SOC. So you have multiple options of seeing the hierarchy, either within the middle panel with the expansion of the plus signs. By right-clicking for the details, it opens a panel on the right side, or by right-clicking with the browser, and it shows you the placement of that term within the hierarchy on the left side. So you have multiple options. Another question?
Great. Our next question is about a surgery taking place in a study. So the surgery doesn't meet the definition of an AE, but the consequence of the surgery there is bleeding. How would you code this without including the surgery?
So you have terms in MedDRA that are specific to post-surgical complications, right? So uh, let's see. If I put surge and bleed and see, and let's see if anything comes up. Okay, so I have operation site bleed, post-procedural bleeding, post-procedural hemorrhage, and if I open them up just to see, are they gonna have different PTs or not? So we have procedural, which could be during the procedure. We have post-procedural, which is after the procedure is done, and we have procedural site, right? So procedural hemorrhage for the site during the procedure. So depending on your verbatim. Now, sometimes you might have information that contributes to your selection of LLT outside of your verbatim. That depends on your company's approach. So if you have the fact that this patient was undergoing a procedure and then they sent you the report of hemorrhage, you know that it happened as a procedural complication, whether intra-op or post-op? Do you use that level of nuance in LLT? I can't answer that for you. So your organization will need to decide, can you use external bits of information outside of the field for the AE to capture the true essence of the report, or do you need to query the site and have them specify that this was procedural or post-procedural? So that kind of response I can't really answer for your organization, but the MedDRA selections are there if you have that level of detail in your report.
Great.
Anything
Our
else?
next question, I think they're referring to the browser, maybe. It says, how do we toggle between the new and old format of MedDRA? So maybe the versions.
Well, if you want to change versions, so here in the browser, you can go down to as far back as 2.1 in English. Not every language will have, all of the older versions. So you can toggle down to 2.1. If you're talking about the new versus old browser, right now they're both available. Like we said, the PTC, not the PTC, the link on the top right corner will take you to the old one. You have to go through tools to get to the new one because it's really still new and it's still undergoing, a bit of addressing. If a few snags are there, it's really brand new. But eventually, the old one will be retired. So we'll give it a bit of overlap, maybe through 2025, and then the old one will be retired, and just the new one will be available. So I hope that was your question, but if not, please come back.
Fantastic. All right. I am not seeing any further questions.
Okay, wonderful. Well, I do appreciate everyone who stayed on the call with us. We did go over the time to address all of these questions and answers, but thank you so much for joining us today. Have a wonderful rest of your day and hope to catch you at a future webinar.